let's say it's the need continues, and so we can make any day a Labor Day. So whatever project it is that you had in mind, if you were not able to do it, please note that there is still time for you to go ahead and do it. And I'm saying this specifically for the Kiwanis Club of Kingston members. I know some of you may have missed the message in the group, but the plans that we had for Labor Day, we'd have to push back because the area of focus, there is some 8 weeks renovation going on that we were not aware of at the start. And so it's recommended that we do the project subsequent to those 8 weeks. So even though you didn't get to do it on Labor Day, it doesn't mean that we won't still need you to labor. So that's why I'm saying Labor Day continues. And what it does is give us additional time to do some planning to ensure that our execution will be done beautifully. And it will give more of you the opportunity to participate, because if it is that you would not have been available over the weekend just gone, now you can make plans and you can put it in your diaries, write it down to make sure that when the new date is announced that you are there for the project. Last week, we had our annual general meeting, and let me say thank you to all the members who turned up to look about the affairs of your club for the next administrative year. Let me say congratulations to all the persons who were elected. I am extremely excited about what it is that you will bring on board and how it is that you will continue the impact of the Kiwanis Club of Kingston while we continue to build on our legacy of service. 62 years going into 63, and I'm looking forward, quite excitedly so, as to what the 63rd year will have in store. Also, because I get to see it from a different perspective. Not that I'll be going anywhere. I'm wherever my club needs me, I will continue to be of service to my club, but it is also quite exciting to have the title, and I'm quite looking forward to it. Immediate past president. But that's for the future. This evening's meeting promises to be an exciting one. We are going to be talking about a virus that has caused many to be in panic mode, and many were considering whether or not it is that we will be going back to year 2020. Let's not even think it, even though it did bring some good things with it because it causes us to embrace technology a little bit more, but there are some things that we would not like to see return. So let's not put it there, but we'll find out more this evening about it, and it is not my responsibility, so I'm not going to do it to specifically welcome our presenter, but I'm sure that the I think it's VP Andrew who will be doing the welcome roll call, would make sure that our guests know how appreciated she is and how grateful we are to have Dr. Tiffany Butterfield with us this evening. So without further ado, I'll invite VP Dr. Andrew Burton to do the welcome.
Hello again, everyone, and welcome to our meeting. And as was mentioned, we have a special guest, Dr. Butterfield, straight out of the Department of Microbiology. She will get her formal introduction will be read before she shares with us. But welcome to our meeting, Dr. Butterfield, as well as any other guests that you have on the call. Special welcome. And thank you for being with us, and we look forward to hearing what you have to share. Do we usually at this time do our roll call, highlighting any Kiwanians on the call. We're 36 strong. Do we have any Kiwanians who are logged in from clubs overseas? Any Kiwanians from international clubs? who are joining us this evening? No? All right. Any clubs from Division 25?
Yes, good night, everyone.
Hi, good night.
Yes, this is President Giovanni from the Kiwanis Club of Hosa Trelawney.
Welcome.
And with me tonight, I have four other members. So it's five of us online sharing in this moment with you guys and looking forward to an interesting meeting where this new virus is concerned. So thanks for having us.
Excellent. Thanks, President Gio, and thanks for bringing your delegation here this evening. Pleasure to have you guys. Anybody else? Any other Kiwanians from clubs in Division 25 who have joined us on the call? All right, just a team, just a group from Coastal Trelawney. Any clubs from Division 24? Anybody representing clubs from Division 24? How about Division 23 East?
Good evening. Good evening.
Hi, good evening.
This is Chair Marlene from Kiwanis Club of New Kingston. I bring you greetings from our President Veronica and the entire KCNK family. Currently, I am seeing four of us online. Looking forward to a great meeting. Thank you for the invite. Have a
Yes.
good one.
Thank you. Thank you, Chair Marlene. Thank you for joining us. I see DLG Gerthlin on the call. Always good to have you here with us.
Thank you, VP Uncle Andrew. Great to be on.
Good evening.
Good evening, Kiwanians.
Excellent. Any other clubs from Division 23 East?
Sure. Good evening, fellow
Good evening.
Kiwanians and guests. This is Director Tanisi from the Kiwanis Club of South St. Andrew, bringing you greetings on behalf of President Carlene and the ladies. They're tardy in coming, so I am alone right now from the club, but hopefully they'll join soon. Thanks for the invite.
Okay, that's alone so far. And we look
Right.
forward to their arrival. Thank you so much, Tanisha. Thank you for joining us. Any other club from 23 East? No? All right. Division 20. Oh, was that somebody else from 23 East? 23 West? Anyone from a club in Division 23 West? None so far? Okay. Our neighbors in Division 23 Central. Okay, excellent. We have a group from 23 Central.
Good evening. Sorry
Yeah.
about that. This is DP Paulette from the Kiwanis Club of Friends Across Borders.
Yeah.
We're happy to be with you this evening. When I checked at the moment, we are two in numbers, myself and DP Bridget.
Okay.
Others are on their way, and on behalf of President Thelma, we thank you for the invitation and we look forward to a very interesting and engaging meeting.
All right, excellent. Thank you, DP Paulette. We do have our usual contingent from 23 Central, sorry, online. DP, Dr. Eurydice, and DLG Desmond are here representing.
PP Robert here from Kiwanis Club of West St. Andrew. Looking forward to a very informative meeting tonight as usual.
Yes.
Currently I'm online, but I bring warm greetings from my club,
Yes.
Kiwanis Club of West St. Andrew.
All right, thank you, PP Robert.
No other members will be coming on.
Okay, all right. Thank you for joining us. Okay, do we have any of our SLPs? And for our guests this evening, SLPs stand for our service leadership programs and the youth, some of whom we are directly sponsored by our club, some who just are part of the Kiwanis family, whether Circle K, young people from universities and colleges, key clubbers from high schools, builders clubbers or K Kids members from preparatory and primary schools. A quick scan, I don't see any on the call. DLG Willie, you confirm? Or if any of our SLP members are on the call, please unmute and share, say where you're from, if present. Also, any guests of Kiwanians, please tell us who invited you, what brought you to the meeting, or if you just saw the flyer and joined, we'd like to hear from you. Or the Kiwanians who had invited guests. If your guest is here, please unmute and introduce your guest. No.
I have a guest, P.P. Andrew.
Oh, yes, please.
Janet McPherson.
Okay.
Happy to see you on the call, Janet. Welcome.
Excellent. Welcome again, Janet. Okay. And I see one of our own joining in from overseas, DP Paul. Welcome from all the way across the world.
Thank you very much.
I look forward to joining the overseas contingent of our club soon. Yes. All right. I think that's it. We thank everyone again for joining us thus far. We're 46 strong now, as more who expected to join come on the call. So I hand back over to President Zuri to continue the proceedings.
Thank you, VP Uncle Andrew, and we are not as excited as you are to have you join the diaspora. We want you to be here for as long as we possibly can have you. I have no apologies for absence, but I'll ask DLG Willie, was any sent to you?
I didn't receive any apologies, President Zuri.
Thank you. To the members of the Kiwanis Club of Kingston, were any apologies sent to any of you and you would wish to share with the meeting at this time? All right, it seems that there are no apologies this evening, so we move to the celebratory aspect of our meeting where we recognize those persons who are celebrating special occasions, be it birthdays or anniversaries, and I will invite President-designate Arsenio Sawyers to do that for us.
Good evening again, everyone. As stated by President Zuri, this is a section of our meeting where we like to acknowledge those in our clubs or on the call who will be celebrating a special day this week. We do have two members who will be celebrating a birthday this week. We have Kiwanian Patrick Barnes, who celebrates his birthday on the 29th, followed by PD Michael Forbes, who will have his birthday on the 30th. So happy birthday to you both when it comes. And if there is anyone else on the call who will be celebrating a special day this week, feel free to open your mics and share with us. Okay, if there is none, happy birthday again to both our Kiwanians when it comes. And over to you, President Zuri.
Thank you, President-designate. At this time, we will have Kiwanis education, and Kiwanis education will be done by DLG Desmond Bachelor.
Good evening, President, UDC, fellow Kiwanians, SLP members and guests. We talk about the importance of Kiwanis partnership. Kiwanis partnerships are highly important because they expand a club's service impact, lower project cost, and increase community togetherness. By collaborating with government and businesses, clubs are better able to address childhood health, education, and youth leadership. Partnerships are vital for several key reasons, and I'll just mention a few. They maximize impact. By collaborating with established organizations, such as hospitals and food banks, it will allow clubs to expand their reach, helping more children and communities than if they were alone. So the whole synergistic effect is so important. Resource sharing. Partnership with corporations or local businesses reduces financial burden and provides volunteers with necessary supplies and funding. And finally, community cohesion, community togetherness. Partnership will bring diverse groups together to unite for a common goal. And that's it for Kiwanis Education, President. Thank you.
Thank you, DLG Desmond. And as per usual, I will encourage us all on the platform to, whenever we find ourselves with the opportunity to try to learn more about Kiwanis International, be it you are a Kiwanian already, or if you are a guest, find out more about this institution and how it is that it continues to serve the world. So at this point in time, we are going to be moving to the main event, and we are going to start that with the introduction of our guest speaker. That will be done by Kiwanian Stephen Levy.
All right, good evening, fellow Kiwanians and guests. The pleasure is mine this evening to introduce our guest presenter, Dr. Tiffany R. Butterfield. Dr. Butterfield is a lecturer in the Department of Microbiology at the University of the West Indies, and she is a researcher in HIV immunology and epidemiology. Her research focuses on infectious diseases, immune responses, and the impact of chronic viral infections on human health, with a particular interest in inflammation and emerging infectious diseases in the Caribbean. Dr. Butterfield has contributed to research and public health initiatives related to HIV, HTLV, and COVID-19. And she is committed to strengthening infectious disease research and public health capacity in Jamaica. Fellow Kiwanians and guests, please help me welcome our guest presenter this evening, Dr. Butterfield.
Hello, good evening, everyone. I hope you can hear me clearly.
Yes, we can.
Thank you very much. Thanks for having me and thanks for inviting me to do this talk. I always think it's very important that we are all informed. Even if we may not have the science background, we can still try to understand what it is that we are facing every day as we go about our lives. So today, I was asked to speak about hantavirus, and I know it's because it's in the headlines. And so I titled it as Beyond the Headlines. No, what you call it, no conflict with Deion Jackson Miller. But just to understand hantavirus, separating the facts, what it is, what we know, from what are kind of some of the knee-jerk reactions that may be coming in. So I thank you for having me, and I just want to first acknowledge that some of my slides were taken from the WHO speakers at the WHO consultation on hantavirus, and these were provided by Professor J. Peter Figueroa from University of the West Indies. All right, so before we get started, I just want to set our stage. I think at this point, we're all very familiar right now. It's been in the news. It was highlighted to us. We got some indication of what was happening. There was a complex and sort of fast-moving emergency that was happening on a cruise ship. There was a little bit of uncertainty at one point in time. One of the things that really stands out is because it's a cruise ship, there is the potential for it to affect many countries and regions. So that was something of concern. There was some amount of uncertainty, and I think that really stems from this virus being somewhat unknown to most, not unknown to the scientific community, but unknown to most in the public sphere. And so it really drove huge media and public interest. And specifically because we all experienced what we experienced in 2020 to 2021, I think it was really just that trigger of, we like to call it the post-COVID trauma, or just naturally hearing about an infection, hearing about some amount of uncertainty, and kind of remembering how uncertain a lot of us were in the early stages of COVID before we fully got a handle on what was happening. And so it is understandable that there are questions. It's understandable that there may be concerns. And I hope that as we go through tonight, I can get you to a point where your fears are assuaged. I'm pretty sure at this point there is some little, like the fear has reduced a bit, I hope, as it relates to hantavirus. And then you may also be able to go into your spheres and be able to speak very knowledgeable about the situation and be able to share what I share with you today. So in terms of the virus and the cruise ship and what happened, it all starts back in April 1st when the ship actually left that southern tip of Argentina. And if you see the picture of that cruise ship, you realize it's not the usual cruise ship. It's not the Royal Caribbean. It's not the party cruise ship. This was actually an expedition cruise ship. So a lot of the goals of that ship was really to go to Antarctica and have them view the geography and the animals. And it was really more of an exploration type of activity with, as you can see, not much passengers, around 114 passengers, 61 crew, but notably they were coming from 23 different countries. So if we think about our globalized world, all these persons, once they leave the ship, will need to be relocated back to where they're from. So that's a whole 23 different countries, which is one of the reasons there was a little concern initially. Now, the ship started off on April 1st. The first patient that actually we considered patient 0. All evidence suggests that this is where it started. They started showing fever and headache and some mild GI symptoms, so like vomiting and diarrhea. From April 6th. So note the date from April 1st to April 6th. They just went on the ship and he started being sick. By April 11th, he had progressed so quickly that he actually died on board in the medical bay. And then the ship actually docked at the island Tristan da Cunha, and people actually got off and explored and did everything. So if you realize that the patient was sick, the patient died, so there is an expectation that whatever is causing the disease is on the ship, and all persons on the ship actually left and were out and about. They came back to the ship, and then by April 22nd, they got to St. Helena, and the patient and his wife, so his body and his wife, escorting that body, flew to Johannesburg. When they got to Johannesburg, the wife quickly deteriorated and unfortunately also passed away in the hospital in Johannesburg. At that point, I think all warning flags started going up that there was a challenge and there was a problem, because by the time they got to Ascension Island on the 27th, another case needed to be medically evacuated to Johannesburg. And then by April 28th, another case developed symptoms on board. And so at this point, there is a clear understanding and a clear knowledge that there's an outbreak on the ship. Something is happening on this cruise ship and there is a problem. And it wasn't until May 2nd that after the fourth case died on board in the medical bay, the WHO was officially notified of this respiratory cluster on the ship. And then by the time the ship got to Cape Verde Islands, Cape Verde actually refused docking because they're saying if this is a medical emergency and an outbreak, we do not have sufficient medical infrastructure to allow for the ship to dock and for the people to come off the ship because we do not know what it is. But by May 4th, they were able to actually identify what it is because the history of where they were coming from, the symptoms that they were seeing when they tested the samples from the wife, those samples came back positive for hantavirus. So it wasn't a case that they needed to make a new diagnostic test to figure out a new virus. This was something that was previously known. And based on the history, they tested the wife's samples and they were able to identify it. So May 2nd, it was notified. By May 4th, we knew exactly what it was. And then by May 6th, WHO publicly confirms it. And unfortunately, the ship's doctor actually fell ill and another crew member actually also fell ill by that time. So between April 1st and May 6th, a number of cases happened, but even within that time, we were able to quickly identify what the pathogen was, and persons were effectively knowledgeable enough to be able to start doing the specific precautions that were needed to manage the outbreak. Then the other thing that happened was that when they all got to Tenerife, because they weren't allowed to go to Cape Verde, they went to Tenerife, all passengers on the ship were able to disembark. They disembarked with very strict protocols to ensure that we're not having this outbreak that has now spilled out of our own control. And they were then allowed to travel on specific flights. So they were no longer on commercial flights, specific flights that were able to carry them to their specific locations. And you can see the different points that they're going. And of interest, we see that they're going to the US. And we always worry about things going to the US because we know our close relationship with the US can sometimes allow for things to get to Jamaica. But I hope by the end you will realize how much of a low risk we are based on the science that I will point out. And then by May 18th, the ship was completely sterilized and disinfected, and the final crew that was on the ship was allowed to disembark. All persons have been disembarked off the ship and they're now in quarantine. And so we are at a point where we have a number of persons who were exposed because they were on the ship. We have persons that have already died and have seen severe disease because of the infection. But we are at the point now where they're off the ship and they're now in their own locations. And so there is still a level of concern from the public about what that means for them. But what I also want to point out is that all 12 cases, so right at May 22nd, there are 12 cases of hantavirus that have been most confirmed. Some of them are very strongly probable, and only because there have not been a diagnostic test to confirm them, but everything points to it being hantavirus. And of the 12 cases, 3 have died. And of all 12 cases, there are persons who were on the ship. To date, there has been no evidence from anyone on the ship transmitting to anyone that was not on the ship. There was a case that persons were concerned about of someone who was on the flight with the wife, but fortunately, when they tested, that person was negative when they were tested. So every case are cases from the ship, and we'll discuss now why that may be actually the fortunate situation that we're now dealing with and why it may not lead to the fear that COVID sometimes led to. And also, when we look at the cases, we see that all of them are very much connected. The first case really is the one that kind of seeded the virus to case 2, 3, 4, 5, and 6. I know this diagram is highly scientific, but the key is looking at the lines, who was in contact with who, and the dotted lines mean probable, and then the ones that don't have a line mean that there has not been a complete contact tracing discussion and investigation of that case yet. But the key here is all of them were on the ship. So that is where we're pretty sure that they got it from the ship. Now they're trying to figure out who they were in contact with to really indicate where they actually picked it up from. So this is where we now go to the hantavirus, because we see what has happened, we understand what is happening, and every time the WHO comes out, they say we shouldn't worry. It's very low risk for pandemic potential. It is not the same as COVID, and they have it under control. And I hope that in the next couple of slides, you'll kind of get a better sense of confidence in why the WHO would say that. So hantavirus was actually something that was recorded to cause infections from as far back as 1951 during the Korean War. A lot of soldiers developed this mysterious illness where they had kidney failure, there was internal bleeding, and they had fever. And then it wasn't until 1978 that they were able to actually find the virus and find that this virus was actually transmitted because of contact with the excreta from this brown mouse that is found in the wild in this specific region. So it's very much a zoonotic infection where we say that it comes directly from animal host, and that is where the human will pick up the infection. And for years, it was believed, and that was the case, that almost all infections of hantavirus were caused because of contact with the excreta of wild rodents. And different regions will have different rodents that carry a different strain of the virus, but the key here is everything was transmitted from the rodents to the human. So if you were not in contact with any rodent excreta, your chance of transmission of this virus was very, very low, and you would probably never actually hear about hantavirus before this situation that occurred. Then after that time, there are a number of outbreaks. So it's not something that is new. As I said, remember with COVID-19, that was a new strain of the virus operating in a new way. This virus has been around. We have seen it. We understand its biology, and it has been happening, as I said, as far back as 1951. And they actually started doing routine surveillance in 1992 when there was an outbreak in the US. And again, this was specifically because of contact with the wild rodent species. In 96, they saw an outbreak in Argentina, and the key thing about this outbreak was the first time that there was suspicion of person-to-person transmission. And this was because of a specific strain called Andes virus, which we've heard about a lot. And that was the first time they kind of had the inkling that there might have been some person-to-person transmission, because some persons who fell ill did not have clear evidence of interaction with the rodents and the rodent excreta, but they were in close contact with persons who were ill because of their exposure to the rodents. Then there was an outbreak in Chile. In 2012, there was an actual outbreak in the Yosemite National Park, 10 cases. In 2016 to 2017, there was another larger outbreak that was multi-state, but they were able to actually tie it down to the introduction of some rats, some Norway rats that were pet rats that were introduced into the US at that time. And that is where those cases were linked with. And this kind of highlights that idea of bringing animals into a different environment and the risk that causes, because that is what really brought the sole virus. So it was a sole strain that is usually found in Asia and Europe that is now found in the US because of the introduction of those rodent species. Then in 2018 to 2019, that was the outbreak that solidified and confirmed that there is person-to-person transmission of the Andes virus. And to date, it is the only strain of hantavirus that they're showing person-to-person transmission. But concerningly, it has a higher case fatality rate than some of the other strains of the virus as well. There were 34 cases and there were 11 deaths, and most of those cases were from person-to-person transmission. So one person got exposed to the rodent and then went to a social gathering and was in very close proximity to persons. And that is what then led to these 34 cases. And then in 2025, there was a surge in Germany, again related to a surge in a specific rodent species in that location, and they got 55 cases. And then even before the ship, there was an outbreak happening in Argentina in that northern region. So not where the ship left from the southern region. In the northern region, there was an outbreak, and it's one of the largest outbreaks to date, where there are 100 cases and 20 deaths. And one of the reasons that persons have suggested that this outbreak may be a little bit bigger than the rest is because they believe it's also the Andes virus, but they also believe that there was very limited quarantining of persons who may have been exposed. And so they believe that there was some person-to-person transmission, and that highlighted to them the importance of ensuring that even though we believe it doesn't spread very rapidly, and most of the cases in other outbreaks have been small numbers, if you do not put proper quarantining and controlling measures in place, you will probably have a real outbreak that may become a major challenge. And so this kind of sets the stage where a lot of this already happened. The science is already there. And so the WHO, the Argentinian officials, PAHO that manages us as well, they were very familiar, very aware of this virus, of this strain and its potential for human-to-human transmission. It did not shock them. It was not something new. And so once they were aware of it, they were able to quickly implement their quarantining and controlling measures to combat and kind of stop the outbreak from spreading any further. And so this kind of gives you a summary of where most of the strains are. We have old world strains and we have new world strains. And when we say a strain of a virus, we say they are closely related to each other, but there are small changes and differences. If anything, I would think it would be more akin to if we talk about races in the human population as well. It's just that there are certain genetic changes that allow for it to now be classified as a different strain because it's now doing something a little bit different. So the ones from the old world were usually going to cause problems with your kidneys, while the ones from the new world are usually causing problems with your lungs. And you can see where that box is, Argentina and Chile, and it's usually the northern part of Argentina and Chile that really have the Andes virus being endemic to those regions, because the rodent that actually carries the Andes virus is actually only found in that region. So it's not something that's going to be widespread. It is only if you are in that region, you have a higher risk of exposure if you come into contact with the excreta from those animals. But then the main thing that really is the concerning piece, and that is why even if it may not be as effective at moving from person to person, that mortality rate is something that is very troubling. 30 to 50% is a very high case fatality rate. And so that is why you need to ensure that if there is an outbreak, you really try to prevent it from ongoing to other persons, because that case fatality rate really does become a major issue. And so how we get transmission, I've been saying it's contact with the excreta. So really, the rodents just carry these viruses. We know that there are viruses that live in animals without causing any sort of infection in the animals. And in this case, that is what is happening. This rodent actually just has the virus in there, and they shed the virus in their excreta, so their urine and their feces. And if that is left to dry out, and then someone comes and sweeps it up, they are going to aerosolize all of that, and they inhale it, and that is when it starts to infect their lungs. So it's really, if you are the persons at high risk, they usually say are farmers from that region, persons who are going to be more in the wild parts of that rural areas of that region, and also persons who sometimes have jobs of going into abandoned buildings and trying to clear them out. They are more at risk because they're going to be in buildings that have these rodents probably coming through, and the risk of actually sweeping up these things and actually getting the dust of the virus to actually be inhaled, and you can become infected. So the key here is that we do not want to do dry sweeping if we're going into any enclosed building that has been abandoned for a while. They always say that you need to do wet sweeping, where you kind of spray the disinfectant first and then mop up the area. But this is the main route of transmission. This is the route of transmission that has been documented the most. So most of those outbreaks, all of them start with some amount of interaction, such as this with the rodent excreta. And so really, most of the outbreaks that happen are going to be zoonotic only, meaning you're only going to have it if you come into contact with the rodent. So that is most cases of hantavirus. Andes virus, which is the virus of concern now, has the potential for human-to-human transmission because of close human contact. So you have to be living in the same household, very intimate, prolonged exposure in very badly ventilated areas. because really it is not as effective. So it's not like a flu where sneezing and coughing just quickly can allow for person-to-person transmission. This really requires a lot more sort of environmental conditions to make it very effective at being transmitted from person to person. But it does happen because most persons will live with their spouse or their homes, they share utensils, things like that will happen, and the virus will be able to spread in those situations. And then what we have recognized, and what has been kind of very limited in other outbreaks, is this multi-generational spread, moving from one person who was the index case to another person, and then that person moving on to someone else. So if you remember the chain that was shown from the actual outbreak that happened on the ship, we believe the first case passed it to his spouse, the wife, and then the wife actually became one of the ones that passed it to someone else. So it kind of created a situation that is not very common. It's very uncommon with the Andes virus, even though it does have human-to-human transmission. It's very uncommon to see this kind of multi-generation spread that we will see with other respiratory viruses. So it's really the job of the investigators to really think about where the person was, who they came in contact with, what kind of situation they were in contact with the person. So it can't just be, a walk past. It had to be a situation where they were actually in close contact with each other for a prolonged period of time, and the situation and environment actually was conducive to allowing for the transmission. And this kind of shows you why, because they have seen that you really need very tight quarters. So they have said it needs to be within a 2-meter radius and within 15 minutes of exposure for you to actually have a transmission event. It's not very efficient. The viral particles will be in the saliva. And so if you share utensils, if you have intimate contact, or if there is coughing or sneezing, there is the potential for it to transmit, but it really requires that prolonged close contact. And what was very fortunate or unfortunate is like the two sides of a coin. As a scientist, it's pretty fortunate to be able to see it in real time happening, but also as a part of the public and the community, you really don't want these outbreaks to happen. But the ship provided such perfect conditions for this person-to-person spread to happen. It's never usually this perfect, but unfortunately, everything just kind of fell into place for the person to be infected, get on the ship, and then sharing these enclosed spaces, poor ventilation in close quarters, the shared utensils, it really facilitated the human-to-human spread that we're seeing in the cases as they come down. It's very clear and it's very apparent that we're seeing human-to-human spread, and it really shows you that the ship just was really an accelerant really for that activity to happen, because normally it's really very hard for Andes virus to spread from human to human. But then there are other things that become a little challenging for persons, especially the medical field and the public health specialists who are trying to keep it under wraps. That incubation period is very long. It is reported to be 1 to 7 weeks. There are some persons that say 8 weeks. And when we say incubation period, we're speaking about the point when you were infected to the point where you actually saw symptoms. So usually it's an estimated number for persons, but it's generally within the 1 to 7 week range. Some persons as early as 2 weeks, but it can go all the way to 7 weeks. But then one of the good things is that the infectivity window is short. So you're not infectious during the period when you don't have symptoms, which is completely different from COVID. One of the things about COVID that kind of just shook up our knowledge and how everything happened was that COVID was actually being transmitted during the asymptomatic carriage, which is not normally the case. And so for this virus, it is actually having an infectivity window that is not related to the incubation period, but during the symptomatic stage, where it is between 2 days before you actually start having the fever and 2 days after they having the fever, it's estimated to be. That is where you're highly infectious, and it's more likely to spread person to person, because at that point, we expect you to have a lot of virus, so high viral load. You're having symptomatic disease, so you're probably coughing and sneezing. And you're if you have close intimate contact during this time, the risk of spread to that person has significantly increased. And so this is why they're talking about the incubation time and how long persons may need to quarantine for. And if we know about human behavior and human condition, telling someone they need to sit in one specific place and not move for 7 weeks is generally hard. It's generally hard to do, and you really need to have their buy-in, and that is why information and speaking about the science is very important as well. So persons really understand why we say the 7 weeks, why we say 42 days when we're talking about actually staying inside and not coming out. But then when the symptoms starts, the other thing about the symptoms, and I think this may kind of highlight, I don't want to say this is exactly what happened, but I believe that in the early stages when the first case got ill, because the symptoms were fever, joint pain, and some fatigue and some nausea, they're very quickly considered to be an acute febrile illness, usually like a flu, usually like a COVID or a pneumonia. Generally speaking, all physicians, depending on where they are, so if he is working on a ship that's leaving Argentina, he should have in his mind the different causes that may cause these acute febrile illnesses. In Jamaica, we know that someone comes with an acute febrile illness. If it's respiratory, we're thinking the respiratory viruses, but we also know we need to always think dengue because we are endemic for dengue. And so the symptoms are so generic, I would say. It really requires an understanding of the area or the place that you are in to really be able to kind of pinpoint what you need to test for. And that is the main thing, because within that day 3 period and within that 3 to 10 day period, that is when you're going to want to do your testing. So you can do a regular antibody test. So you give a blood sample and they're able to test to see if you were exposed. There's also the PCR. So if you remember COVID, when we did PCR to actually find the viral products themselves, that is also possible. Currently, the PCR is only found in reference labs. It's not a test that is going to be widespread. And also for the IgM test, it's not something that is widespread. It's not something that we have on hand. If you're not in an area that is endemic or that worries about the hantavirus, you're not going to have these tests on hand. Your reference lab will, and the case here, our reference lab, which is the Caribbean Public Health Authority, they have it on hand, but the general testing facilities won't usually have these tests on hand. But the case here is that in the early days, it looks very similar to everything else that you're dealing with. But then it needs a definitive laboratory diagnosis to be able to really state that this is what it is. And you really need to test them over this early symptomatic phase. So it's within 3 to 10 days, because sometimes the earlier test may fail and you need to do a follow-up test to be able to find it within that 3 to 10 days. And why it is important is, if you remember from the slide, the first patient, he got ill on the 6th, but he was dead by the 11th. Because that's the thing about hantavirus, and that is why the mortality rate is so high. The severity just becomes very rapid. It's like a rapid onset. Within 24 hours, you may move from just simple fever and a little coughing to shortness of breath and shock and sepsis and overt and inflammation, and you start having hemorrhaging within 24 hours. And so timing is of the essence. And that is why it's important for those persons that we have in quarantine to actually be being tested routinely. And the minute they have symptoms, they're actually addressed and treated, because you do not want them to actually get to this point where they actually progress very rapidly. And so what we talk about when we talk about the pulmonary syndrome for the non-medical field, it's really you're drowning from the inside. It might sound very morbid, but that is exactly what is happening. So we know our lungs should not have liquid in it. It needs to be empty for our air sacs to be just empty so they can fill and release and have the oxygen being able to be passing between the blood and the lung capacity. And so that is our healthy state. What happens in hantavirus infection is that your blood vessels become so leaky that they now start leaking fluid into your lungs. And so when you start having fluid into the lungs, you're now preventing your body from being able to do the oxygen exchange. So if you're not getting enough oxygen, we know our entire body requires oxygen to function. So if you're not getting enough oxygen, you actually can push yourself all the way to fatal result because you're no longer able to breathe. So that's what we say when we're saying drowning from the inside. It's like your lungs are filling with fluid just because your blood vessels have now become very leaky and allowing everything to leak into your lungs. And the not so good news is that there is no approved antiviral cure. And I can go on a soapbox and speak about equity and the fact that this affects a small region and it's usually not the developed Western regions that have this condition. So a lot of funding may not be available to really investigate treatment options and vaccine options. So there is no approved antiviral cure. There has been some effectivity of some that have already been used for other things, but the timing of using that has been very crucial, because if you miss the window when you can use it, it becomes completely ineffective. And so timing, again, as we talk about the timing to diagnosis, the timing for treatment is also very important. There is a vaccine, but it's only for the Seoul strain that is in Seoul, and it's used mainly in South Korea in their armies, and it's not licensed for international use. So the reality is that there is really no cure, and there's no widely available vaccine. And on the outlook, I would say that a vaccine has been delayed somewhat because most vaccines for hantavirus have not even passed a certain point to actually be starting to be used in humans. They still haven't been fully tested out in animals. And so we're at a point where we really don't have a vaccine fully available for hantavirus. But the good news is the body's immune system can fight the virus, just that the body would need time to do that. And if we remember the slide before, the leakiness of your blood vessels into the lungs is rapid, and so sometimes you lose that time. So that hemorrhaging state becomes a major challenge. And if you're still watching the news now, you kind of understand the hemorrhaging is the main issue with Ebola as well. And so it's like your body doesn't get the time to fight because your body really starts having to try to figure out how to survive this full-on hemorrhaging that is happening. So the ultimate takeaway is that we need to get help at the first sign of flu-like symptoms if you've had direct exposure with a rodent, or in the case of what's happening now with somebody directly coming off the Hondios ship, because it's the early support that you get, the early medical intervention that you get that actually will enhance your chances. Because if you remember from the slide on the cases, the third case is still actually alive and stable in the ICU in Johannesburg, and all the other cases are alive and being treated and managed. We hope that it remains that way and they actually recover and go forth. And so from a standpoint of threat assessment, so from what we just said, it's very hard to transmit first person, even though it does do person-to-person transmission. There are so many things that are required for efficient person-to-person transmission that your risk really is pretty low if you kind of stay away from persons and the persons who have exposure are quarantined. And then the other thing why you will hear the WHO say that they really don't see this being a major challenge is when we think about our viruses that severely have pandemic potential, these are the ones that mutate very rapidly. So they change themselves so quickly that they can sometimes change how they operate. But with hantavirus, as we have seen from 1951 till now, there have been not much changes. It's pretty stable, and it's really related to the fact that it kind of just lives in the rodent and it doesn't need to worry about fighting anything else. So it kind of just stays very stable and it doesn't really mutate very often and doesn't really mutate much at all, because the sequence that they have, so the strain that they have from the ship, is actually so identical to the one that caused the outbreak in 2018, where we actually confirmed person-to-person transmission. And so the thought and the science tells us that if this was to actually become a severe threat of human-to-human transmission, it would require so much mutation and so much evolutionary changes that the virus itself just does not do. And so we're pretty confident that it will, if we contain persons who have been exposed, treat those who are infected, we can actually just have the virus peter out until it's no longer able to infect anyone else. And so really and truly, what I hope you were able to see was that this outbreak was just really a perfect storm. It's not a novel virus. It wasn't a mutation that changed anything. It wasn't anything that was new. The biology and how the virus operates is standing true to itself. It hasn't done anything that has made us worried about how it's operating. And it's really just the environmental and logistical factors that kind of came to play at the same time that just made this situation happen as it did. The person who we consider patient zero, I know we've heard in the news that they were in that northern region. So remember I said the northern region is where the mouse is that usually has Andes virus. And he was actually in areas that we assume mouse and that kind of excreta would be. He was in, they said, in garbage collection areas. And so there is the consensus that we believe that that is, the science tells us that that may have been where they acquired the pathogen. And then because of that long incubation period, so he was in that region for weeks before he got on the ship. But because of that long incubation period, by the time he's boarding the ship, he's able to bypass the general check. So, you know, the general checks is just to check if you have a temperature. By that time, he had no fever because of that long incubation period. And so he was able to get on the ship and introduce the pathogen to the ship. And then a cruise ship, enclosed cabins, insufficient ventilation, shared airflow, prolonged proximity. This is a ship that is traveling to Antarctica, so they're not really coming off the ship. They are staying on the ship. It really acted as an amplifier. And that just unlocked the rare transmission potential of the Andes strain. So it just happened to be the Andes strain that is able to do person-to-person transmission in this specific type of environment. And so that is where we have the ongoing transmission in the ship. And so that's why we see all those cases from persons who were on the ship. And so really it is just being able to monitor and manage all those persons on the ship, because we do assess, and the WHO does assess, that all persons on the ship had a moderate risk of exposure. And so they all need to be monitored. For those who are symptomatic, they're monitored in a clinical setting. Because remember, as I said, the symptomatic is when you're able to actually release the virus into the air. And so they are in rooms that have airborne infection isolation rooms. So it really monitors where the air flows, if it doesn't really get released back into the regular airflow of the hospital. For the asymptomatic ones, there's actually community monitoring. So I know some persons were concerned when they saw that persons were allowed to actually quarantine at home, but it's really due to the moderate risk profile that they have. Anybody on that ship is allowed to monitor at home if they have no symptoms, and they will be monitored for 42 days. They're tested as they come off the ship. They will be tested at 21 days, and then they'll be tested at 42 days. And then anyone who shows symptoms, because they're going to be monitored so closely, and they need to do check-ins with their public health officials, the minute they show signs and symptoms, they are going to report it to their public health officials, because I'm sure they have imparted the knowledge that how important it is for early treatments as you start seeing symptoms. So we expect that this will peter out if we continue to monitor these persons. And then anybody who comes into contact with these persons, so there is concern about some of the persons who were on the plane with the second case when she left and went to Johannesburg, those persons are also under quarantine. And so the WHO has done its job in really ramping up its ability to quarantine, monitor, and share that information effectively, give the correct information to the different areas where persons will be located, so that the public health system in those areas can be activated and ready to manage all these patients and all these persons as they are being monitored for this time. And so the WHO, the CDC, and the European CDC has basically said there is no big threat to the the CDC says no big threat to the American public. It is low. WHO says the risk for persons who are on the ship is moderate, but the risks for everybody else is very low. And the risk for the general population in Europe is also very low. So the thing here is that while the case fatality rate is high, the requirement for the close contact and the prolonged close contact with these individuals, or even the need for the person to actually be very close contact with you, or even to come in contact with the rodent itself, we're pretty confident by the science that if we monitor, quarantine, and control, the infection will basically peter out until there is no longer anything to worry about. And so I hope I was able to assuage some fears. I hope you understood some. I tried to make the science as palatable as possible, but I'm open now for any questions you may have.
Well, thank you, Dr. Butterfield. That was a lot of information to consume. I want to just, we're going to open it up to the floor, but just let me give it a start, a jump start. You said there's no vaccine except for the Korean strain or whatever. So when you say treatment, what are you treating? Are you treating it just like a fever, how you treat for a fever, or is that what you're doing?
Yeah, so you're basically just maintaining the patient. You're just kind of treating the symptoms. We're not treating the virus. We're not getting rid of the virus. We're just treating the symptoms. So they're treating the fever. They're treating the shortness of breath, ensuring that the patient is on oxygen so that they never really run out of as much oxygen as possible. And you try to maintain and keep them. In some cases, you need to put them on ventilation. You need to kind of remove some of the fluid from the lungs if it's really bad. And so you're doing a lot of that. Usually ICU level treatment for persons who start having kind of severe symptoms.
And would somebody with asthma be more vulnerable?
Respiratory infection, somebody with asthma is extremely vulnerable to severe challenges. It's an inflammatory condition. Asthma is an inflammatory condition, and for hantavirus, for the leakiness of the blood vessels that we're speaking about, it's because of inflammation. And so you are compounding the issue. It can elicit some sort of asthmatic reaction. It can lead to further challenges in the actual infrastructure of the lungs. And so, yes, persons with any sort of respiratory issues, challenges will be at an increased risk of severe disease, as is the case with persons with hypertension, persons with diabetes. As we said, if anything can turn your immune system to not do what it's supposed to do, there is a potential for the viruses or bacteria or any other pathogen to be more severe than normal.
And I had heard that there was no quarantine or in fact, there are some people on that ship. Didn't you hear that there are some people who are from the Caribbean? I think I heard that.
There was one person from St. Kitts and Nevis. That's the only person that I have heard about. In terms of the actual activity that is happening in the specific locations, remember the WHO can provide recommendations, but they can't
enforce them.
They can't force. But we do have one thing about COVID, and I mean, it might be the bad and the good of it. It did kind of revitalize a lot of investment in infectious diseases and the ability to actually monitor and manage infectious diseases. Hopefully nobody forgot what it is that they needed to do. And so even in those locations where persons are going, they are taking heed to the precautions and following through. There's one instance where there was a little breakdown, but I think they caught it very quickly. If you heard about the actual hospital that was disposing of the waste, they actually didn't dispose of the waste properly, and the persons who were disposing the waste were not fully protected. And so all those persons were put in quarantine because they were thought of to be exposed.
And where was that?
Netherlands or Norway? I think it's an N Netherlands, Norway. It was in Europe. It was in Europe.
Okay. Fellow Kiwanans and guests, the floor is open. You may have questions. Please don't be shy. And you don't have to just put them in the chat, because we like when the discussion is vocal. But if so please try and get your questions answered.
Hi, good night, Dr. Butterfield.
Good night.
I just want to know, do you think based on how we we handled COVID and any previous pandemics in the past, if Jamaica, how vulnerable we are in terms of if something by chance happened here and there was an outbreak, do you think that we would be able to manage and effectively deal with it?
The infrastructure is there. The infrastructure is there to manage and deal with it. We have COVID did allow for us to have different testing modalities available to us at the National Public Health Lab, also at UHWI. And so the infrastructure is there. I can't speak so confidently sometime in public sentiment and public behavior. But a lot of these things really relate to how we communicate with the public, and how then the public responds to that communication and then buys into the communication and then be able to actually operate within those realms of whatever directives are given. So in terms of if we're able to manage the infrastructure, the health system may have some challenges, but I think if we communicate effectively, which is one of the main things with public health, you will be able to get the public buy-in, the public's own community response. Sometimes we need to look at how important the community response is to public health. It's not so much the hospitals and what we're doing in the hospitals, it's really what the community is able to do. And so that really stems from knowledge and being able to communicate that knowledge effectively and getting them to act accordingly.
Thank you for that question. How should our behavior change or at all now? Just now. We haven't seen anything in Jamaica yet, but is there any behavioral change that we should be conscious of?
I wouldn't say it's a change because it's something that should normally be happening, but hand hygiene, that never goes away. Ensuring that you practice proper hand hygiene. Usually most of the cases is our hands that pick up a lot of things and then introduce it to our bodies. At present for hantavirus, because it's such a low risk, it's very hard to say, you need to change and start doing this and doing that. And then also because we know that the actual rodent that carries Andes virus is not found here locally. Well, it hasn't been reported to be found here locally. It's not so much to worry about how we manage the rodent excreta, but just in general though, if you're dealing with a location that may have rodents and has evidence of rodents, you need to be very careful. Proper masking, proper gloves, proper protective equipment, proper procedures in how you're going to clean the environment need to be managed, because it may not be the Andes virus, but it may also be another hantavirus strain that may infect you and cause severe problems for you. So you need to also be very aware of that. And just in general, we sometimes like to say, oh, it's just a little cold and somebody comes to the office. Generally, once you feel a little ill, usually when you're starting to have symptoms for most infections, that is when you're able to pass it on. And so if you're having any infections, if you know somebody has any symptoms, it's generally the best practice to kind of stay away from others.
Okay. Okay, I checked the chat and I don't see any questions in the chat. So it seems as if you did an excellent job in giving us a good feel for, but one thing I didn't quite understand. We talk about the hantavirus and then you mentioned the Andes strain. I'm not sure what's the connection between what happened on the cruise ship, because you said the Andes strain, it can be person to person. The regular hantavirus is not. But when did Andes strain come in?
As in, when did the strain come up to be?
When did that come into the picture? I mean, because you're saying that we have had person to person. Was that historical?
Yes, so historically they had information from 1996, the first recorded information of person-to-person transmission of the Andes strain, and then confirmed in a 2016 to 2018 outbreak in Argentina. And so that is when they had their confirmation that there is person-to-person transmission. So it is something that has happened in that specific region. It hasn't been seen anywhere else for any other hantavirus.
Okay.
And so it's only the Andes strain that
But
does that. So the idea is that we believe patient 0 was actually in that area going to do his bird watching, got in contact with the rodent, got infected, and then ended up on the ship and started exposing other persons on the ship.
the ship vehemently denied that they had any rats on the ship. I think that I guess they're trying to get rid of any liability. But you're saying the evidence supports that?
The evidence supports that he brought it onto the ship.
Okay.
The evidence supports that he brought it on the ship. If we look at the chain of transmission, you can see that most of the persons were in contact with each other. And it wasn't somebody who was not in contact with them, because there was a point where on the ship, they quarantined everybody on the ship. And so it was those persons, there's no evidence currently of anybody else on the ship who was not in contact or in contact with somebody that was in contact with them who got it, which would have been evidence of some amount of exposure from the ship. So everything points to patient 0 being the main way that the virus got on the ship.
Okay. Well, I think we seem to have covered it. President Zuri, I don't know if you had a question or if you wanted to just take it from here.
No, I just wanted to thank Dr. Butterfield
Hello?
for being with us this evening.
Somebody speaking?
Yes, good night, Doc.
Good night.
Question. Treating the symptoms, what drug would you recommend best if the symptoms do develop?
So I am not a internist, so I don't have the full list what the ICU doctors would have, but there is over the counter for fevers is fine, but I'm just saying that in terms of once it becomes severe, you definitely have to go into the hospital and they will have. So you're not to treat by yourself. You are to get medical help for something like hantavirus infection. It's not a run-of-the-mill flu. It's not a run-of-the-mill cold. It can, as I said before, get very rapid progression. And so the minute you start seeing symptoms, if you were exposed, so remember, it all comes back to if you were exposed, then you should definitely get medical intervention immediately, because they have all the equipment and things at the hospital sites to be able to properly manage that condition. Shouldn't be self-treatment.
How would you know if you were exposed? I mean, you can get a fever and it's just a normal fever for some, anything.
The likelihood of you being exposed currently is very, very low, unless you know somebody who was on the ship and in contact with somebody who was on the ship. Because the persons who were even on the plane, none of them have come down with any symptoms currently, and they're still in their incubation period, still in their quarantining. But those other persons who would likely be the point where it can start probably coming off the ship, they're not showing any signs, and they were, well, quickly enough addressed and put into quarantine. And so ideally, if you are not in any location where you're seeing evidence of rats and mice, you shouldn't worry as much. But again, always think about your own history. I know sometimes you go to the doctor and the doctor asks you 1,000,001 questions. It's really very important, because it really gives them an indication of what is happening, because exposure history is very important to how we manage and treat.
Okay. Well,
All
with
right.
the World Cup,
Thank
with the
you.
with the World Cup coming up and the people from Argentina, is that a risk?
All right. DP will probably have to take that after. I don't want us to be pressuring Dr. Butterfield too much to go into areas that she's not quite prepared or equipped to deal with this evening. All right. So to do the official vote of thanks, I'll invite Kiwanian Sadiki Davis.
Hi, good evening again, everyone.
Good evening.
Dr. Butterfield, on behalf of the Kiwanis Club of Kingston, I would like to sincerely thank you for your informative and timely presentation and understanding the antivirus. We appreciate how clearly you walked us through the history and timeline of the virus, helping us to understand that this is not something new and that effective control measures can be put in place quickly. Your explanation of the early support needed to manage and fight the virus was especially helpful. Importantly, you remind us that with the right information, there is no need for panic or hysteria, only calm, informed action. So again, thank you for sharing your knowledge with us in such a clear and reassuring way. So we are truly grateful. Thank you.
Thank you for having me.
Thank you. And thank you as well, Sadiki. Usually we have a certificate of appreciation that we give to our guest presenters. We will ensure that you have your certificate as well. We will figure out how to get it to you. Thank you again so much, Dr. Butterfield, and always, 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 you're open to join us whenever you are able to. Or Sergeant at Arms is still enjoying his time in Canada, and so unfortunately, you will all have to pay for that with another blanket fine. And I do hope that our members are taking note of the blanket fines and are putting things in place to have their debts settled with the club. This evening, we'll only be taking $300 from each member. And DLG William Reeson, we now invite you to bring notices and opportunities and to tell us about Friday and the annual Charity Barbie Fry, as well as any interclubbing opportunities.
Thank you, President Zuri. Fellow Kiwanis and guests, let me first draw your attention to our third quarter district divisional council meeting, which will be held on Saturday, June 6th at the Kuna Mutual Building. That starts with registration, as I said, at 9 a.m. Near to home, Friday, Barbie Fry. This is our annual Barbie Fry, which will be held at 11 Fairway Avenue, Kingston 6th. The venue is actually at the corner of Fairway Avenue and Windsor Avenue, just behind the AC Hotel on Lady Musgrave Road. It begins at 10:30. Tickets are available. Cost of a meal is $3,500. There will be a choice of 3 meals: escovite fish, barbecue chicken, or crispy pork. Which, as I said, we still have a number of tickets, and we're hoping that by Friday morning, we will have distributed all the tickets. So anybody on the call who has not received a ticket or purchased a ticket may contact President Zuri or myself. My number is 361-1436 for tickets. Let's make this a successful Barbie Fry. After later in the afternoon, we're hoping to have a lime where we'll be just having fun and fellowship. Again, the next fundraiser after this is on July the 18th. National Dance Theatre Company Benefit Performance. This opens on the Friday, the night before, on July the 17th. And the Artistic Director has given us the first benefit performance, which will be held on Saturday, July the 18th at 8 p.m. More information will be coming out shortly regarding this. The tickets are at $4,000. Hopefully, we can partner with other clubs interested in partnering with us within the division. I know that Western Time have indicated their interest, and Kiwanis Club of Barbican. Those are the notices and announcements in respect to interclub opportunities. I will be sending a circular in respect to the interclubs for the remainder of the week. We know, however, that it is the Kiwanis Club's capital city will be celebrating their 30th anniversary, and that's going to be held at the headquarters at Betting Game and Lottery, where they meet officially. And it starts, I think, at 7 o'clock, and the entrance fee or registration is $2,000. So for now, those are interclubbing notice. Over to you, President Zuri. You may want to open it to the other clubs who are visiting with us. Thank you.
Thank you, DLG Willie. Before I do that, just to remind members and to advise others who are on the platform who may not be aware that the Thanksgiving service for the life of our dear DP Earl Spencer will be this Thursday, starting at 10 a.m. at the St. Margaret's Anglican Church, which is in Ligony. So just a reminder, the Thanksgiving service for the life of DP Earl will be on Thursday, May 28th. I think Thursday is the 28th of May, and it starts at 10 a.m. All right, so at this point, I'll open to any person who's on the platform who you have an event or an announcement that you want to bring our attention to. You could go ahead and do so at this time.
Good night, President Zuri.
Good night.
DLG Whaley, DLG on your board, members on the chat. President Maurice here from the Kingston Club, west of West St. Andrew. We'd just like to advise you we'll have our 47th anniversary on the 3rd of June at the Medallion Hall Hotel. This event starts at 7 p.m. and we're looking for a good turnout. We have some entertainment as well, and a little lime is expected at the end. So you come on all and can turn out for our 47th anniversary at the Medallion Hall. Thank you very much.
All right, President Maurice, thank you. And we always look forward. You can go. I encourage you to go. The Arden drummers are quite exciting, so I'm sure you will have a good time with them. So I am also endorsing my fellow president's anniversary meeting on June 3rd and ask that you make every effort to be there as well. Is there anyone else on the call?
Yes, good evening.
Good
evening,
evening.
everyone. P.E. Dakers raised from Kiwanis Club of Young Professionals St. Catherine. We'll be having a benefit play on July 5th rather, at 8 p.m. Hurricane Attacklaps at the Little Theatre in Kingston. So we're inviting and encouraging persons to support our benefit night by purchasing tickets and attending. It's $3,500 per ticket, July 5th, 8 p.m., Little Theatre, Hurricane Attacklaps.
You want to share with us how we could get the tickets? Who we could contact?
They can call me at 368-8477. I can post a number in the chat. I work at the Bustamante Hospital for Children, so they can reach out to me, or President Candice Thompson, who is our current president, and she works at the Victoria Jubilee Hospital. So I will post my number in the chat for anyone who is interested in purchasing and supporting our benefit night.
All right, thank you.
Yeah, President Zuri, I'd also like to add, I don't know, we've missed that important part, that the cost for the ticket to enter the anniversary is $2,500, and it's payable at the gate. And you can also contact me. I'll tell you the banking details if you feel so free to transfer. But the cost is $2,500, and we're accepted upon entrance.
All right, thank you, President Maurice. Anyone else?
President, I have a question.
Okay, for any other business or for announcements?
Actually, well, you can take it on any other business.
All right, so we'll just close this out and then go to any other business. So
Thank you.
going once, going twice, going 3 times. All right, opportunity gone. So no, any other business? PDT Raston, you could go ahead.
Thank you, President. By the way, it was an excellent presentation. Very, a lot of information was shared, and in such a manner that the whole delivery and the command of the subject was very interesting. My question, the club has just announced 2 fundraising events. So we are collecting money. I don't hear how we're spending that money with projects. I have a project that I'm proposing to the club, and it's really the sickle cell unit is celebrating World Sickle Cell Day sometime in June, and they want us to continue the project that we started in painting the building, and now to do some beautification around that building. I've spoken to DLG Willie about it, so I just want to sensitize the club and providing an opportunity for you to spend some of that money that you'll be making on Friday and at the other event. Thank you.
All right, thank you, PDT Rasta. But there are several projects in the pipeline that require spending that are on hold right now. But we will discuss that one as well at the board meeting. I'm sure DLG really will bring it there, and we'll put it with the list of other projects that we have that's waiting in the pipeline. And then we will make, as long as we are able to help, we are open and willing to help. Anyone else with any other business? All right, there being no further business, we move to our thought for the week. Is DP Marcel on?
He's not present, unfortunately not.
All right, is there anyone from the club who wants to share a thought? Well, if not, I will just encourage us all to continue to be our brother's keeper and to give a helping hand wherever it is that we can. Kiwanians, guess all, I now invite you to raise your glasses with me, be it imaginary, literal, figurative. Raise your glasses with me in a toast to Kiwanis International and to Jamaica, land we love. This meeting of the Kiwanis Club of Kingston is now terminated. Have a great evening, everyone, and we thank you so much for being with us this week. Do join us again next week.
Very good. Very good.
Good night.
Good night.
Good night, President Zuri. Good meeting.
Thank you, IPP.
Is Dr. Butterfield still on? No?
I don't think so, Desmond.